the autism program as it's forming at UT Southwestern and Children's is a relatively new undertaking. And it's getting the institutions together and getting the strengths of the institutions together to provide a higher level of service for the community and advance our research and educational missions at the same time. So I'm going to be providing an overview of some of the research findings in autism, some of the areas where major advances have been made over in recent years, and then provide a little bit of an introduction for the structure of the Autism Center as it's forming, so you all know about that. And the other speakers are our colleagues in the center who will be providing, I think, important information about neurological early detection, speech and language, and social and school relationship aspects for kids with autism. There'd be some good, useful information for everyone. So thank you all for coming. This is a Saturday morning. We're all just worked the week, and so I'm really grateful you all took the time to come here. So, okay. We move forward. So I need to, of course, tell you about the disclosures. We've had a fair amount of grant money supporting biological treatment studies and imaging and EEG studies of autism to learn about the nature of problems in the kids, and also a relationship with drug companies, of course, to kind of get some translational models working to get new treatments into patient care. So, autism. All of you are living in the world of recognizing how much more common that is than we believed it to be not all that long ago. See, some of you in the audience have about as much gray hair as me, and I think thinking back as when we were in training, there certainly was a lot less introduction to this to autism as a clinical problem, to recognizing the prevalence of it and the intervention needs of the kids. So. It's something that over the last 10 or 15 years has really picked up in national recognition and importance, and it's led a lot of major medical centers such as ours to try to really grapple with the problem academically and training and so on. So what are some of the important key features of autism? I think at this point it's important to recognize it as a general clinical syndrome. It's probably comprised of a number of different disorders, so it's probably the autisms. But right now we're living with a generally described clinical syndrome that we're still doing research to parse into different component disorders. It's characterized by a relatively simple set of features. First, in the social domain, that there is difficulty in social interaction. There's difficulty perceiving emotional states of other people, understanding the emotional and mental states of other people. And also that leads to there are serious language problems in a lot of the kids, but there's a use of social relationships to guide communication with other people that's really a core feature of this illness. The other key dimension that's received a bit less research attention, but is a real significant behavioral problem later on in life, is the domain of restricted and repetitive behaviors. It's a behavioral rigidity. It's an anxiety with change that leads many of these kids to become very distraught, and it really creates significant management problems for parents, distress for the child, and it's probably the major reason why a lot of these kids are brought for psychiatric attention and receive psychiatric medications, especially as they get older and bigger. Onset, of course, it's a neurodevelopmental disorder. Onset is it's in very early childhood, and one of the big struggles that we have in this field is developing better approaches for early detection so that we can catch it earlier, because the only real effective treatment we have for this condition right now is high quality behavioral interventions. And Tessa Van Kirk is leading our behavioral intervention program at UT Southwestern. And I think what's clear from the work in this area is that early detection, guiding early intervention, is the one thing that really can significantly improve outcomes in these kids. So we're really trying to learn how to efficiently provide that service and how to provide it to as many people as we can. So that's really important take home, especially for those using practice, that get people for diagnosis early, get intervention started early is really important for improving outcomes in the kids later on. Another point, treatment options outside of the of the behavioral interventions that we have available, such as ABA therapy, the pharmacological interventions are limited. It's a high priority for us as a group to develop new treatments and new interventions that can be effective for patients. But now the symptoms, the medications we have are mostly for symptomatic control, so the treatment options remain limited. Early detection, I emphasized already. I won't emphasize it. You may think I'm saying this too much, but early detection is really important for outcome. And I think the last point is that we have a lot to learn about the pathophysiology of this condition from a neurobiological, neurodevelopmental perspective. And we're fighting feverishly to get that with animal models and clinical studies. And it's really crucial that we make that kind of headway so that we can learn to develop new interventions that are going to be more effective for the children and hopefully curative instead of palliative. So, autism. I'll try to provide some overview slides here. Autism was basically considered to be a condition defined in three ways: the social impairment, language and communication deficits, and the restricted and repetitive behaviors that I told you about. There's been a lot of research as people are preparing for DSM-5 about how these things are working statistically together, and there's been a growing recognition that the social impairment and the language impairments are highly related, so they're kind of being reduced into one syndrome group, and Dr. Wiles will be talking about that aspect of things a bit more. Asperger's has been traditionally considered a condition that is a kind of a subgroup of generally higher functioning individuals who are primarily in the social impairment and repetitive behaviors dimensions, high on those dimensions, but not very strong on language and communication deficits. There's again, you look at the numbers, it doesn't look like there's a unique syndrome like that, and there's still a lot of argument about that in the field, even in the New York Times. But that's probably in DSM-5 as things stand now. That's going to be discontinued as a clinical diagnosis, and we're going to be talking about autism spectrum disorder as a unitary syndrome, which probably makes the most sense given the data that we have available now. So this is a slide from Autism Speaks website. Autism Speaks is, for those of you who haven't heard about this, Autism Speaks is the American Cancer Society for Autism. Jerry Dawson runs that. It's a fantastic organization that is involved in fundraising and in providing informational resources to families. It's a place to start. Get on the Autism Speaks website for families. They will learn a huge amount that will be really informative for them. But one of the things on the website when they're interested in convincing people that autism is a real problem is this presentation of prevalence rates estimates. Back in 1975, we were in 1 in 5,000, 1 in 10,000 recognition. Now we hit a couple of years ago 1 in 100, and estimates now are getting closer to 1 in 80, and that's CDC data. So this is not a rare condition. You think of 1 in 80 of the kids coming through your clinics are going to meet criterion for autism on average. It's a highly prevalent condition. It was under-recognized. We didn't do enough research to learn about what's causing it. We're making headway now, and but this kind of prevalence estimates are really kind of scary, and they seem to be going up. There's a lot of dispute in the field about whether this is increased recognition. To some extent, that's certainly true. Another issue is that a lot of the kids with milder variants of autism weren't meeting diagnostic criteria and then weren't eligible for services, and this created a real big problem. So the diagnostic criteria, I think, reasonably and appropriately were made a little more liberal so that people could get the care they needed. And there's also the issue about whether we actually are having some increased prevalence of this condition because of some environmental factor. Lots of research going on to find such things. Not much of that is very successful to allow us to identify environmental factors. There's a few things: increased parental age. It's hard to know what the mechanism is for that, but the environmental factors that are accounting for increased prevalence are really very poorly understood at this point, and there's a lot of work at NIH trying to sort that question out. This is the third and last time I will beat this drum. One of the findings that came out of the behavioral intervention research which has grown and picked up a lot of pace over the last 5 years especially, is the finding from these studies is that the earlier that cases are identified, the better the outcomes are going to be. And I told you I was going to say that too many times. This will be the last time, but it's really a crucial point. Finding these problems early and getting them to a clinician who can provide intervention services really changes the outcome. Getting somebody identified close to the age of 2 leads to a better outcome than waiting until they're 5 and getting in school and getting identified, because the social interventions are much less effective at that point. That's kind of consistent across different research studies. So that really has implications for all of you in practice, because you, of course, are the people who are the screeners that are going to identify these cases. Okay, an overview of the complexity of autism. This is a nice slide that Jeremy Veenstra Vanderweel, a psychiatrist at Vanderbilt, and Randy Blakely, a neurobiologist there, put together in a paper in Neuropsychopharmacology a couple of years ago. And it really, it's a nice presentation of much about autism that reflects this complexity. So if you kind of, I'll start kind of working my way around the circle this way. There's a language impairment that I spoke about. There's intellectual disability. Many of these individuals have low IQ, although as we've softened up the criteria for the diagnosis, the rates of intellectual disability are of course lower. Genetic research. There's a lot of GWAS type studies trying to do population studies to find genetic causes of autism. That's largely been pretty unsuccessful. People study 1,000, 2,000, 5,000, 10,000 cases, find some genes. The next person that does that has a hard time replicating that. We're still kind of scratching the surface of developing a systems biology understanding of the different genetic factors that are interacting and contributing to the disorder. There is a better evidence now for copy number variation, so increased copy number variations in a number of genes that are related to autism. This kind of work has been much more effectively replicated. So that this is kind of really a promising area of work over the last few years. Rare variants. There is disorders such as Fragile X, and Dr. Evans, I think, will be speaking about that. We have a Fragile X clinic. Those rare disorders have prevalence rates of autism in the order of half to 2/3 of the patients will have significant autistic features. Those kinds of illnesses are really important, and we're very interested in studying them very intensively because we think we can learn some basic principles that will be useful for application to the broader group of individuals with autism in the future. So a lot of the research emphasis right now in our program and NIH is going at these rare variants right now. So what are some other things? Hyperserotonemia. One of the most robust biological findings in autism is a sequestration of serotonin into cells, into platelets. 30 or 40% have of cases have a marked increase in serotonin in platelets. There's a lot of interest in this serotonin hyperserotonergic state because of its potential implication for driving rigid and repetitive behaviors. It's kind of like an OCD-like syndrome where serotonin is very important. So there's a lot of interest in that serotonin in terms of the restricted and repetitive behavior dimension. A lot of immune abnormalities. Mitochondrial indices are abnormal. In neuroimaging, besides the seizure sites that can be identified with studies, there's a lot of gross anatomic change, cortical thickness. 20% of cases are believed now to have a cortical overgrowth up to the age of 5, and then a gradual reduction in atrophic changes, so that by the age of 12 it's normal, and by the age of 18 a lot of these kids have less cortical volume, cortical gray matter volume than average individuals. So there's this atypical profile of overgrowth and probably apoptotic changes that are reducing cortical volume after that. Macrocephaly is an aspect of that, sometimes persistent, sometimes transient in early development. Abnormal EEGs. A lot of the best EEG data is older when there was a more conservative diagnosis of autism in the literature, but in that literature, roughly 30% of cases had epileptiform abnormalities that need to be worked up clinically, obviously, and seizure rates are high, especially in some of these rare variant conditions. Constipation. there's especially potentially related to the serotonin and gut motility link. There's the constipation is a significant problem in autism, and a lot of the kids need medical workup, GI workups, because of that. Then you get into the psychiatry side, high levels of anxiety, agitation, hyperactivity, and impulsivity. Behavioral problems are very evident, and especially as kids get older, a lot of them really need psychiatric care, maintenance with psychiatric medications to help kind of take the edge off, cut the severity of these symptoms. So what this all leads us to is a very complex array of disorders where genetics are very complicated, the implications on brain are very complicated and vary across subgroups of people in progressive ways. A range of other biological disorders that require active involvement of neurology and GI in the medical care of these patients, and then psychiatric management. So it becomes a clinical condition where we need to have multiple experts working with the patients, the pediatricians, the neurologists, the psychiatrists, the psychologists, the speech and language people, to really provide the care that these kids need. And that's why these multidisciplinary centers are forming along the lines that we did at Southwestern. So let me just provide a few highlights about research findings at this point. Autism is probably the most common, most heritable of the common neuropsychiatric disorders. So twin studies, heritability estimates, the genetic contributions to autism are very high relative to other disorders that we'd see in neuropsychiatry, from Alzheimer's to schizophrenia. So the genetic components are important. Our efforts to make headway are progressing in. Hopefully, we'll find some mechanisms that would provide some treatment suggestions for us. Mendelian, kind of simple Mendelian risk is low. Rare mutations, as I said, were important. GWAS results I mentioned have been relatively underwhelming and more importantly inconsistent. And the CNV findings have been a little more exciting, actually. This is some data from the Yale group. A friend nicely sent me a slide. It presents data on the de novo CNV rates in autism. And these are relatively large samples. There's samples in the 800s of probands and siblings in comparison. Number of de novo CNVs, you can see the really marked increase in rates of CNV in the probands, even relative to their own siblings, much less to the common population, the general population. So duplications, deletions, most of these are alterations that lead to hypofunction in gene production and gene expression. So that's we're learning that. We're starting to put together an understanding of what these different CNV increases, what the biological impact of them are, learn about what kind of systems are being affected, and hopefully in time we'll find some common systems being affected that will be developed as treatment targets. But the genetics are really of this disorder are starting to finally come along a bit with this approach. Another finding in autism is it involves the cerebellum. So I don't want to take a lot of time with this story. It's something we're pretty interested in. A lot of the symptoms of autism lead you to be concerned about areas of the brain supporting social communication, affective responsivity, language skills, a lot of cortical areas, and clearly these kind of lines are important. But the histology, the histopath work that's been done so far in autism, in that work, the most important common finding has been problems in the cerebellum, particularly in the vermis. So there's a fair bit of motor control problem in patients, dyspraxia, recognized clinically, but the biology of this disorder seems to be important, and we're learning a lot about how the cerebellum through the nuclei projects up to cortex and regulates cortical functions, and so it could be contributing not only to motor problems but also some of the dysfunctions and higher cortical functions requiring integration across brain systems to support behavior. So we're pretty interested in that. It's an important line of work. A few kind of simple findings from the lab over time. One is ambidexterity. If you look on the left, you can see the rates of left-handedness, mixed-handedness, and right-handedness, kind of arbitrarily defined, but reasonably in a large clinical sample a few years ago. Then you look at the cases of autism that don't have early language problems. You find that the rates of ambidexterity going up to about 40%. And when you look to those with disordered early language development, the mixed-handedness is going up to 60%. So ambidexterity is a real problem. It's potentially a sign of cortical specialization, hemispheric specialization that's functioning in abnormal ways. And there is a lot of imaging, functional imaging and EEG data consistent with that. And I'm not going to go into this today, but we're very interested in this problem. And some of this hemispheric specialization, lack of left hemisphere specialization, seems to be familial in individuals with autism. And we're kind of going after the genetics now of that particular characteristics of patients. Lots of fancy ways to look at motor control in the lab. We have an eye movement lab using approaches we kind of borrowed from animal work and neurology clinics, where we have patients look at lights move around, pursuit systems, saccade systems, look at the integrity of their motor responses, often abnormalities. We work with kinesiologists to look at manual motor control, force generation, force stability, problems in patients and also in relatives. And the third thing we do, highlighted on the bottom, is use functional MRI studies to look at how brain's controlling motor systems. So for those of you who don't work close enough to an MRI center, so your friends are grabbing you into fMRI studies to see how your brain works. Basically, this is a technology that's developed over the last 15 years. In the mid-90s, it really was developed to allow the use of MRI scanners to detect changes in brain physiology over time, so that as you move your right hand, your left motor cortex becomes active. As you process visual information, you can see changes in your visual cortex. As you think of complex problems, your prefrontal cortex becomes active. So it's a way of tracking the functional integrity of the brain in a similar kind of way as you use a treadmill to look at the functional integrity of the heart. It's kind of a challenge test. And so we use that a lot clinically to learn about what areas of the brain are functioning normally in different clinical conditions now. And this is, when we started doing this kind of functional imaging work, you'd be at a meeting where there were 3 or 4 people. Now there's meetings with 7,000, 8,000, 9,000 posters up of people presenting these kind of work using this technique. So we're learning a lot about brain organization that's really providing a systems neuroscience understanding of brain that's going to be helpful for understanding neurodevelopmental disorders like autism. This is an example of some saccadic eye movement data, just to let you know the severity of the problem in some of these cases. If you look on the right here, this is like a series of eye movements to a 10-degree laterally displaced target. People are pretty good about getting right there. A little bit of undershooting as typical in people, but just a lot more variability in motor control in patients with autism. Something also increased in their first-degree relatives. This is kind of consistent with what I was telling you about functional MRI. This is a paper we had out a year ago or so, arguing that a lot of this new information that's come out of systems and cognitive neuroscience to portray the richness of and complexity of brain organization and the importance of interaction of different cortical areas to support behavior. I mean, I think we used to think about, the Broca's area does speech. It's one area of the brain does one thing. It's clear now that when you do these functional imaging studies, that multiple areas of the brain are working together to support behavior almost always. And it's that functional integration of brain systems that's so important. And it's becoming more and more used to develop, to evaluate early phase drug development and things we want to do to evaluate the effectiveness of our treatments on actual brain function in patients, to learn about how they're working and to evaluate their efficacy. So a huge amount of work in this area is in kind of basic psychology labs, neurology labs, is things we can use to advance future work and treatment ideas. This is an example of an fMRI study. I throw it up because when we do these studies, a lot of times you have a hypothesis, you find things you're interested in, but sometimes you're kind of stunned by novel things. So I'm going to try to take you through this quickly. This is this is an fMRI study where the patients lied on their back and simply did a saccadic eye movement test, things you would do clinically. Look here, look here. We do it with dots. The patient looks at a screen and we monitor their response. So we found the kind of deficits in areas that we were looking for. So these are cortical areas and premotor cortex that are involved in eye movement control, the frontal eye fields, the supplementary eye fields, the cerebellum. So we found hypofunction in these patients, which is not so surprising since they have a hypokinesia and increased variability in their eye movements. But the other side of the slide showed something really kind of quite surprising. One of the things that's really been important about learning about complex thinking, problem solving, abstract thinking, is the dependence of a complex circuitry in the brain to support that, involving anterior cingulate cortex, dorsolateral prefrontal cortex, striatum, dorsomedial thalamus. These circuits that Peter Strick has done so much work with anatomically over the years are involved in an integrated way to support higher cognitive function. And the really dramatic thing was while people with autism were performing this simple sensory motor task, they have to utilize that complex circuitry, and including the dentate nucleus of the deep nuclei that's also involved in sending projections to the thalamus to contribute to the modulation of that circuitry. All of these areas that are supposed to be supporting cognition in cases with autism is supporting simple sensory motor function. So major brain systems are being retasked to support things they're not supposed to be doing, and the implications of that for cognitive development are really interesting. If your brain developmentally is retasked so that parts of the brain that are supposed to be doing something are not being tasked to do that, they're not going to be there as resources as cognitive development proceeds, and that could lead to some of the cognitive problems we see so commonly in individuals with autism. Treatment. We clearly we need better treatments. We need treatments that are targeting disease mechanism. We need targets that are going to fundamentally change brain development early on so that we cure instead of manage the patient. So that really is the target for much of this work. Where we and others are kind of pushing from the genetics to identify the genes that are involved, to identify the link of those genes to disease, to elaborate an understanding of its expression and the function of the genes at a biochemical level, and also understand at a cellular and a systems level how these systems are working, and create model systems for animals that allow testing of these models, and then bring those ideas into clinical trials as targets. And that's something we're very, very much emphasizing in our program. There's really important advances being made, especially in these rare variants like Fragile X, tuberous sclerosis. We're understanding the genetics, the mechanisms in cell physiology, the impact on brain development, and the ability to test drugs there that normalize the physiology so we can bring those strategies into patient care. So the challenges of our work in this area in drug development are first to learn what the best target is and to work with pharma to get the drugs developed to tackle the target, to attack the target. The other is evaluating treatment outcomes. A lot of these kind of studies with neuropsychiatric disorders to evaluate drug effect, you kind of, is the patient a whole lot better? And it's kind of a crude outcome measure. So as in other areas of medicine, we want to do trials where we're looking at how the target organ is affected by the drug and look at that in relationship to outcome. So that gets us into being very interested in using high density EEG, functional imaging, and other kind of sophisticated behavioral approaches for evaluating treatment. So we're developing them, and we're doing them in translational way with colleagues in the preclinical world. So just as an example, we're interested in looking at EEG effects related to illness, EEG alterations in illness, EEG effects of drugs. We can now go back and take a little mouse, a knockout model, and put a 16-lead cap on the mouse and do EEG studies of evoked potentials in the knockout mouse, and actually look at drug effects in that model and use that to guide forward direction of drug development. So there's a lot of exciting work going on that's going to lead to some drug development, both in our ability to know what to go after and to how to evaluate that effect. I'll just take a minute or two to tell you about the programs at UT Southwestern that are being developed. On the research side, we're contributing to large population studies, collaborating with other sites. That we're very much pushing the preclinical integration of animal and patient studies for learning about alterations in brain systems that we can target with treatments. we're very interested in resolving the heterogeneity of autism. It's kind of this big syndrome. We've really got to parse it down into discrete biological entities that we can more selectively treat. And a trials program is, of course, crucial to all of our advances. That slide really work here. The Autism Center, as I was telling you before, the care for individuals with autism really needs to be multidisciplinary. And I think what our view of this is that we need to be working with the community pediatricians to facilitate early identification, and then we need to be able to provide resources so that when a patient's identified, there's a real sophisticated program with experts that can get the diagnosis right early. It's really kind of scary. Some of the larger community studies are finding 30-40% error in accuracy of diagnosis. A lot of the diagnoses are done in the school system. We really need to get that, which is both late and inaccurate. So we need to have a program that provides kind of tertiary resources for accurate early detection. So once we have cases and identified, the trick then is to have the other people together in one place to work on the evaluation and care of these patients. So we have developed an autism center. We're bringing the different components of patient care for autism across the UT Southwestern Children's systems into one center. It will involve pediatricians, psychiatrists, the ABA program, Tessa's ABA program that I told you about, integration with basic sciences for the drug development efforts that we're involved in, connections with the imaging resources to really do very sophisticated MRI studies, huge advances. It's almost hard to keep up with better ways to look at white matter tracks and to be able to look at the lateralized alteration and their alteration and effect on brain systems that we're doing is really an exciting line of work. The PEDS neuro group is really obviously crucial given the epilepsy and a host of other medical problems associated with disorder. The Collier, many of you living in this area will know that Collier has a wonderful, long-standing reputation for outstanding speech and language care and research, and we're collaborating with them so that they're going to send their clinicians over to help with our diagnostic program and also get involved in our research programs for evaluating outcomes. And we have a very active psychology group for academic testing for the kids that are starting to have problems in school. Identifying what kind of problems they have in a sophisticated way is really crucial to get educational interventions targeted correctly for them. So we want to help with that and also detect early cognitive problems and intellectual problems so that treatment can start earlier. So multidisciplinary. It's going to be a great experience for the residents rotating through to see how all these disciplines work together and contribute to patient care and evaluation. The patients will all be coming in one place, so we'll have the ability to do research studies on a large enough group of people to actually do trials, and we'll be able to really provide, I think, much better, less fractured patient care so that you don't send somebody to a psychiatrist and get psychiatric care, to a neurologist and get neurologic care. We want everybody working together, talking together about the patients and getting the right treatment plan. So that's our vision. We really want to be a tertiary care program for the community. We can't take care of everyone, but we can do a few things that are really important. We can help with early evaluation and get the diagnosis right early. We can make treatment recommendations early on that I think would be really helpful. We can consult for patients that are behavioral management problems where standard care isn't working and the psychopharm is just kind of, that sometimes it's not uncommon to find patients on 3-4 medications, gradually increasing them, and to find behavioral problems just persisting. And at some point you get to a point, well, what do you need to do? And we want to be a psychopharm consultation service to help with those kinds of problems. The bench to bedside clinical trials program I told you about, and the interdisciplinary training programs will be key to the center. So one clinic for diagnosis, triage, and consultation for the community. Ease and simplicity of patients in the community. They know where to, one place to contact and not kind of call around different departments hoping somebody will see them. The integrated interdisciplinary service delivery. the clinical services across the age span. We're starting now with pediatrics, but we're starting to build some adult clinics. Obviously, these aren't lethal diseases. These kids get older. We want to be able to provide some services for the older kids as well along this tertiary care model. And I list our intake number here, and I'll leave that slide up. So I think this would be a good place for me to stop. There's time for a few questions if someone would like to ask some. And again, thank you all for getting up in the morning to come hear these presentations. So.